All right, so last chapter. So we're going to go ahead and take a deep dive into the lymphatic system and immunity. Now, we've already kind of talked a little bit about this when we talked about the cardiovascular system, since there is a link between the two. However, here we're going to get more in detail with the different lymphatic organs and immunity as a concept. So some of the things we're going to do in this video, we're going to talk about the major functions of the immune system, the different immune cells, bone marrow, the formation of blood cells, the thymus, secondary immune organs, cytokines, and the defenses that we have, both innate and adaptive. So we're going to kind of just do a big overview of the lymphatic and immune systems. So we have to define some terms before we get too far into the weeds. So when we're talking about immunity and resistance, we're talking about the body's ability to fight off cancer and pathogenic cells, as well as things like viruses, right, and whatnot. So it doesn't mean that it doesn't get into your body or anything. It just means your own body's ability to fight it off. So that if a cancer cell pops up, your immune system can destroy it. If you are exposed to a specific pathogen, your body can fight it off so that you are either not sick at all, or you are very mildly ill, and that you overcome it, that you get better. Now, if you don't have this resistance or immunity, then we call this susceptibility. You're susceptible to getting ill. You're susceptible to getting sick. And this is, if this is serious, right, we consider this an immune deficiency. There's something with your immune system you are deficient in that is leading you to get ill more often than you should, or to things that the average person would be able to easily fight off. And when it comes to our resistance to developing diseases, we can look at two sides of this coin, innate immunity and adaptive immunity. Innate immunity is something you're born with. These are just general mechanisms you have to defend yourself, general protection against pathogens. We don't care what the pathogen is. Innate immunity are structures or pathways that are used to fight off a plethora, a large range of different pathogens. And I've been saying the word pathogens, and I feel like I should probably quickly define that in case we've forgotten, but a pathogen is some sort of microorganism that can make us sick. They can be viral, they can be bacterial, they can be fungal, right? Whatever. There's a laundry list of things, but generally speaking, we're talking about some sort of microorganism that can cause illness. So innate immunity, these are things you're born with. It's not going to fight off against a specific pathogen. It's going to be a very generalized response. And then there's adaptive immunity, also sometimes called acquired immunity. Adaptive immunity is where we are activating specific lymphocytes so that we can fight off a very specific pathogen, right? We've adapted to fight off a very specific pathogen. So for example, let's say we've gotten the flu before. We would have lymphocytes then that have adapted to be able to respond to that specific flu virus. And the other tissues and cells that are helping carry out all these responses, these immune responses, are a part of what's called the immune system, also part of the lymphatic system. So we've talked about the lymphatic system as it pertained to the cardiovascular system when we were talking about how we moved fluids, but here we're going to be focusing on the immune responses of these tissues, so we're going to get a little bit deeper in. And when we look at the branch of science that deals with or studies this particular branch, we call it immunology. So if we look at the overall function of the lymphatic system, we've already talked about some of them because it helps with other body systems, like the pulling up of excessive fluid in the interstitial space, and then putting it back into the cardiovascular system so that we don't have a buildup of fluid in the tissues. We talked about lymphatic systems linked to the GI tract when it comes to the absorption of fats. But the one we haven't really gotten into is the first one on this slide, and that is the protection against infection and cancer, again, called immunity. Immunity against infectious causing agents, immunity against cancerous cells. So there's a handful of key components in this system. Number one are immune cells. These are going to be white blood cells. Now, we've been introduced to the white blood cells, but we're going to get a little deeper into what they do and how they work. Lymphatic vessels, again, these are one-way vessels that move lymphatic fluid, not blood, so that it can be cleaned up and dumped back into the cardiovascular system. That lymphatic fluid or lymph, again, this is what flows within the lymphatic vessels. It's very similar to interstitial fluid, which makes sense since the lymph is, the lymphatic vessels or lymphatic capillaries are generally just pulling up that extra fluid. And then the lymphatic organs and tissues, things like red bone marrow, the thymus, the spleen, lymph nodes, and then what's called MALT or mucosal associated lymphatic tissues. We see that associated with things like the GI tract. And then soluble factors. These are going to be small, like protein-based things like interferons, cytokines, complement proteins, antimicrobial peptides, interstitial fluid, and lymph. These are just things that we can find dissolved in there. These are smaller components that are used as well. So let's go ahead and talk about immune cells first. Immune cells are basically the soldiers. They're the ones who are recognizing and getting rid of pathogens and cancerous cells that we don't want in our body. There are a handful of different types. Some we've already kind of talked about, at least on a baseline level, and that includes neutrophils, lymphocytes, which can be categorized as B, T, and natural killer cells, monocytes, eosinophils, and basophils and dendritic cells. So again, some of these we have already talked about. Others are going to feel a little bit new, or at least we haven't seen them this semester. Now, leukocytes that we find in the bloodstream we call white blood cells, but not every leukocyte is found in the blood. We also have things like mast cells and macrophages. These guys are actually found in the tissues. They're not in the bloodstream. And we'll talk about where those guys come from because they do originate in the blood and then make their way into the tissues where they lock down. White blood cells are able to get there because they can migrate to tissues through what's called chemotaxing and extravasation. So chemotaxing, basically this is the movement in response to a chemical signal. So they are like moving towards a specific chemical. And then the extravasating, that's going to be just moving from the blood, like inside the blood vessels to the outside of the blood vessel. And so this is what's going to happen if we do have an infection, if we do have a pathogen found, when we get to the inflammatory response. Now, I mentioned the mast cells and macrophages and how these guys are not found in the blood, but they do originate in blood. Namely, they originate in the blood in the form of the monocyte and basophil. So the monocytes and basophils are in the bloodstream, but when they make their way out of the blood into the tissues, they will differentiate into a macrophage and mast cell. So a monocyte will become a macrophage, a basophil will become a mast cell. And once they've done that, they are stuck. They cannot go back. So let's go ahead and talk about these different immune cells, these different white blood cells and whatnot. Everything we see here is a white blood cell, so we'll talk about them that way. And we can break them down based on a couple things. Number one is granularity. Basically, some of these are going to be granular and others will not have apparent obvious granules. So the granulocytes, these are the ones that have obvious granules, are going to be things like the neutrophils, eosinophils, and basophils. Now these ones, they have these little vesicles that are visible when we see them under a microscope, so they have a grainy appearance. So that's why we call them granulocytes. Generally speaking, when we stain them, neutrophils appear like a pinkish purple. Eosinophils take on a more reddish hue, which is where the eosinophil part comes from. And then the basophils keep kind of like a blue violet, right? They look a little bit more of a blue purple rather than a pink purple. And then there's some other things we'll get into in just a second with that too. But the others, the lymphocytes and the monocytes, their granules are not very obvious. We don't necessarily see them under the microscope when we use a light microscope. So monocytes, lymphocytes, dendritic cells will fall in this category. So that's one way we can identify them. The other way we can identify them is through how their nucleus appears, or what we call nuclear morphology. So we're just saying, how does the nucleus look? When we look at the granulocytes, we notice that they have what's called a multi-lobed appearance, meaning the cell's nucleus has these little lobes, right? Generally speaking, when we look at a neutrophil, we're seeing 3 to 5 of those lobes, right? And it's fewer than that when we look at the eosinophils and the basophils, but we see that bilobed or multi-lobed, right, nucleus. When we look at the agranulocytes, like the lymphocyte and monocyte, we don't see that lobular appearance. With the lymphocyte, it's very round, right? It's a very round, it takes up a lot of space inside of that cell. And then with the monocytes, we see kind of like a horseshoe or a kidney bean shaped nucleus instead. So if you think about the granular appearance and the nuclear appearance, you can use that in combination to very easily identify these cells. So what do they do? If we talk, some of this should be some review, but let's go through it anyways. Neutrophils, these are phagocytic, meaning they will engulf and destroy pathogens. They are first responders to an infection, meaning they're the first ones to show up and to start destroying whatever pathogen there is. They're going to be helpful with getting rid of bacterial and fungal infections. And these guys are innate, meaning they're basically going to go after any pathogen they can possibly come across. They're going to try. The lymphocytes are more specialized. So we have a couple different types. We have the natural killer cells, we have the B cells, and we have the T cells. So natural killer cells are cytotoxic, meaning they're going to get rid of cancerous and virally infected cells. So basically your own cells that have gone haywire because they're either mutated or have been infected with the virus. B cells are going to produce antibodies, and then T cells are going to produce cytokines as well as help with that elimination of cancerous and virally infected cells. And we'll get more into the lymphocytes in a little bit. Monocytes are also phagocytic, similar to the neutrophils. They are also responding very quickly soon after the neutrophils, and they do the same thing with bacteria and fungal infections. They can help eliminate those. These are the ones where they're monocytes in the bloodstream, but as soon as they enter into the tissues, they will differentiate into a macrophage and lock in. Eosinophils, these guys are cytotoxic, and they're generally associated with getting rid of parasites. So things like, usually we're talking about worms or what we call helminths. They do have a nuisance role in allergic disorders, meaning that when they act out of line, basically, this is where we can have allergies develop. Basophils will degranulate in response to allergens, and what they do is they will basically help promote inflammation by releasing histamine. And since they're releasing histamine, that means if you've had allergies ever, you know that you may take antihistamines to help. So you can imagine basophils also play a nuisance role in allergic disorders as well, that they can be responsible for allergic reactions. And then the dendritic cells, these guys will process antigens as well as show the antigens to the T cells, sometimes what's called an antigen presenting cell, basically to help teach T cells, hey, this is who we don't want around. So they're going to help with what we call the adaptive immune response or adaptive immunity. And then the mast cells, again, the mast cell is a basophil that has moved into the tissues. They are going to play a role when it comes to the inflammation that happens in the short term. They're going to release things like histamine. So just like the basophils, they also can be part of someone having allergies. And then lastly, the macrophage, which is originating from the monocyte, right? Similar job in that they're going to be phagocytic. and they're going to be playing a role in short-term and long-term inflammation because they're going to be releasing a lot of signals, right, to help mediate inflammatory responses as well as cytokines. All right, now we get into the lymphatic vessels. Lymphatic vessels are going to we have larger vessels. We also have lymphatic capillaries, right, which will, again, just work alongside the blood vessels to pull up extra interstitial fluid so that we don't collect fluid in the tissues and then return it back to the cardiovascular system. Within this lymphatic fluid inside these vessels, we also circulate white blood cells to help with that immunity. When we return lymph to the cardiovascular system, we have two main ducts for that, the thoracic duct and the right lymphatic duct. Now, why we have two different names, right? Why not call them left and right lymphatic duct? I don't know. But the thoracic duct is going to handle the left. The right lymphatic duct will handle the right. The thoracic duct, though, kind of goes beyond just the left because it's going to be the left side of your head, neck, and chest, your left upper extremity, but it also will handle like your down in like your pelvic, your abdominal, your pelvic, and your lower legs, right, on both sides. This is going to drain into the left subclavian vein, and then the right lymphatic duct, which is basically handling the right side of your head and your right arm and like the upper right part of your chest area, that's going to drain into the right subclavian vein. So the thing you just have to remember is that they drain into the subclavian vein, and remember who's on the left, who's on the right. So these lymphatic vessels, they start as these lymphatic capillaries in the tissues. They have these little flap valves that allow fluid to go in but not necessarily leave. And so that we can pull that extra interstitial fluid up into the capillaries, forming lymph or lymphatic fluid. And then these capillaries will merge with the larger lymphatic vessels. They are still relatively thin, and they do have valves similar to veins to prevent the backflow. So all of this extra interstitial fluid, it's going to drain into lymphatic capillaries through these little openings. We go from lymphatic capillaries to lymphatic vessels to lymphatic trunks to lymphatic ducts to the subclavian vein near the heart. So that's the pathway we're taking. The lymph is going to flow because of what we call a milking action of skeletal muscle and the respiratory pump. So it's, like I said, it's really similar to veins. We have the valves, and then we also use the skeletal and respiratory pumps basically to either use that change in pressure like the respiratory pump is doing with blood, but also the squeezing, when muscles contract, the squeezing on these lymphatic vessels that will push lymphatic fluid up through their valves. Now, when things go wrong with the lymphatic vessels, we can develop what's called lymphedema. This is going to be an excessive amount of interstitial fluid. Usually we're looking at the limbs, and at least in the lymphedema case, this is because there is some sort of problem with lymphatic drainage. Either something's been destroyed or blocked, maybe we've had surgery, maybe we've had to have radiation. Something has happened that has damaged those vessels. And when we have all this extra fluid, in addition to the swelling that we have just from the fluid physically taking up space, it can also trigger inflammation that will lead to permanent tissue changes. And so that can make it very difficult for the, or impossible for the tissue to revert back to normal. Now let's go ahead and get into lymphatic organs and tissues, and in those cases we have two categories, primary and secondary. Primary lymphatic organs are going to be extremely important in the formation of immune cells, and so we have two. The red bone marrow, because this is where we are producing blood cells, and the thymus, where we are developing T cells further. The secondary lymphatic organs are where we have these B and T cells to help mount a response. So they're not produced there, but they are found there, all right? And so we find these adaptive immune cells like the B's and T cells in places like the lymph nodes, the spleen, and the malt-like tissues, so things like the Peyer's patches that we find in the GI tract, the tonsils, and the adenoids. And the tonsils and adenoids are going to be what we find in the head. So let's talk about some of these. Let's go into the thymus first. Now this is where we are developing T cells. Without the thymus, the T cells will not develop. It is going to be this butterfly-shaped endocrine gland just over the heart, just like kind of in front of it / above it, kind of, sort of. It's kind of like superior and anterior to it. It is not the thyroid. You may have heard the thyroid being described very similar in terms of the butterfly-shaped gland. It is similar in that aspect, but it is lower. It is more inferior compared to the thyroid. And so the thymus is going to produce a couple hormones like thymosin and thymic stromal lymphopoietin. This is going to help with the T cells development. And the thymus is kind of interesting. It's kind of strange in that your thymus is very large when you are born, but as you get older, as you reach adulthood, it actually starts to shrink. This is what's called thymic involution, where we are shrinking down as we get older. So it's really large and active when you're young, and then again, it gets smaller over time. Inside the thymus, we find what's called thymocytes, or progenitor T cells, and the structure of the thymus contains a lot of lobules. Basically, we have, like here, we have this lobule. You see it kind of defined as this one kind of roundish or hexagonal patch here. Dividing each lobule, we see the trabeculae, right, that are seen here in that lighter color. Which, again, that's going to help separate one lobule from another, and then we are encapsulated as well. Each lobule is going to have a cortex and a medulla as well. We get to the red bone marrow. This is going to be a somewhat semi-solid tissue. This is going to have things like fibroblasts, fat, immune cells, stem cells, because this is going to be where we are producing blood cells, namely what the process called hematopoiesis. So hematopoietic stem cells, or HSCs, these guys are multipotent stem cells, meaning they can give rise to multiple different types of cells. However, all of the cells they produce are different blood cells, but they're all the blood cells, basically. Red blood cells, white blood cells, and platelets. Now, when we look at the adults, we find these in the open spaces between trabeculae in spongy bone, and we find that spongy bone in our vertebra. We find it in the epiphyses, or the ends of the long bones. We find it in the hip bones, and we find it in the flat bones, like the skull, the sternum, the ribs, right, so on and so forth. So we find this in a lot of different places. And so let's go ahead and talk about hematopoiesis a little bit more. Again, this is just the process of making, developing, and differentiating and maturing into the different formed elements, meaning red blood cells, white blood cells, and platelets. We start with like this one cell to start, called the hematopoietic stem cell. This can give rise to any of the blood cells we need. And then depending on the signals we receive, right, we will start to get a little bit more specialized. So like if we come into contact with interleukin 7, right, then we will develop this way into a common lymphoid precursor. And then going from there, depending on which other interleukin we are being messaged by, like interleukin 3 or 4, 2 or 15, right? We can either, if it's 3 or 4, we can become a B cell. If it's 2 or 15, we'll go to a natural killer T cell precursor, and then 2 takes us to a T cell, 15 takes us to a natural killer cell. That's all going to be down this pathway. But let's say our hematopoietic stem cell is it's exposed to GMC, SF, or interleukin 3, then we'll become a common myeloid precursor. From there, right, if it's GMC, SF, we're going to go down the line to become some of these other white blood cells, right? Whereas interleukin 3 is going to take us towards the red blood cell route. So let's go interleukin 3 to start. We get to a megakaryocyte, or erythroid progenitor. If it's EPO, we're going to become a red blood cell, and from erythroblast to an erythrocyte. And if it's TPO, or interleukin 11, then we become a megakaryocyte, which then develops into platelets. go back to that common myeloid precursor. If it's GM-CSF, we get a granulocyte macrophage progenitor, and then MCSF takes us to the macrophage dendritic precursors, interleukin 6 to a neutrophil, interleukin 5 to eosinophil. We don't know the precursor to go to the mast cell, though. So going this direction, we don't actually have an answer as of now. If we become a macrophage dendritic cell precursor, right, we can either go straight to a dendritic or to a monocyte, and then interleukin 6 to a macrophage. But again, another question mark. That means that there's some of this stuff we don't know yet. And you'll notice there's a lot of IL numbers. Again, this is just an interleukin that is going to help signal to help differentiate these cells. Now, looking at this diagram, we know that our blood cells have various lifespans. Some of them last days, others last years. So something like a red blood cell is only going to last a couple months, right? About 4 months. Whereas some of these, like memory cells that we have for long-term immunity, can last years and years and years. They do, whenever they're gone, they have to be replaced through the hematopoietic process so that we have normal levels. Right, because you wouldn't want your red blood cells to die and not be replaced. So things like EPO can make sure that we're replacing the red blood cells as they die off. Now we have a ratio of different elements. This is going to be constant under normal conditions. What we call steady state conditions are basically when you don't have a disease. This means we have a routine white blood cell differential. All right, going on to the lymph nodes. The lymph nodes are going to be where a lot of our adaptive immune response is going to be kind of stemming from because we have B and T cells found there. This is going to help protect us against pathogens that are presenting in the tissues and lymphatic fluid. So these guys are not necessarily like right into the bloodstream. When we look at the lymph nodes, we have about 600 of them. They're pretty small. They're about, half an inch, basically. It's 1 to 2 centimeters, which is about half of an inch in size. Little tiny bean shapes that are connected through all of these lymphatic vessels as well as blood vessels. So we have kind of both blood and lymphatic connections there. They're going to be found all throughout the body, but we can find them in specific regions. The ones you're probably familiar with are ones that are in like the cervical region. Some of them are going to be more anterior, some more posterior. We also have some like the axillary ones that are in the armpit, right? And then inguinal and femoral, right? All over the place. Those are just a couple examples. The reason I bring them up is sometimes like when people get certain cancer treatments, sometimes the lymph nodes are taken along with it. So a good example of that is when someone has breast cancer. They may have some of the axillary lymph nodes removed as well as breast tissue removed. So we find these guys in these set regions. Again, they have a lot of B and T cells there. Those are the main types of cells we find inside of them. And when the lymph nodes are draining, that's going to help filter that lymph, right? So as the lymphatic vessels, they're going to bring lymph to the lymph node, and then the lymph node is going to help filter that lymph out. So the cells inside the lymph node, basically, as fluid comes through, antigens are going to be found in that interstitial fluid. The cells there, like the B and T cells, will recognize and respond to those antigens in those fluids. For example, too, they're only going to handle certain areas. So like the popliteal lymph node drains into the lower leg and the foot. Next one is the spleen. The spleen is where we have some adaptive immune responses as well. Again, more B and T cells. And so the spleen has a couple different jobs. One, it removes old red blood cells when they're circulating around. Maybe they're damaged, maybe they're dying. We need to get rid of them. The spleen can help remove them from the blood. We can store red and white blood cells and platelets. So you can actually have a lot of blood in the spleen. We have immune responses against the antigens in the blood because some sort of trauma, a bite, some sort of infection that has been traveling. We have blood vessels that are servicing it. but not lymphatic vessels servicing it. So we don't have lymphatic vessels draining into the spleen. So we don't drain lymphatic fluid. We're only kind of working with blood. And there's two different sections to the spleen, what we call pulp, the red pulp and the white pulp. The red pulp, which makes up the majority, is going to deal with red blood cells, hence the name. It's going to help with getting rid of the old red blood cells, recycling the iron, and getting storing platelets, storing blood so that if we have some sort of trauma happen, we can mobilize that blood in the response of shock. And then the white pulp, this is very similar to a lymph node, right? We have immune cells like white blood cells found in these nodules for an adaptive immune response as well. We then get to MALT. MALT is going to be mucosa-associated lymphoid tissues. That's what MALT stands for. This is going to help with mounting an immune response at mucosal sites. So anywhere we have the mucosae or the mucosa level. So we find these in the lamina propria. So this is going to be in the mucosal layer. We find these membranes in the GI tract, the respiratory tract, the urogenital tracts, and their job is to absorb and help protect us against infection, right? It's where we can kind of conduct some immune surveillance. So we have a couple different malts that we can find. There's the bronchus-associated malts called the BALT. This we find in the lungs, Peyer's patches in the small intestines, and then tonsils, which are in the oral cavity and the pharynx. Next, we have some other smaller components. We have the cytokines. The cytokines are a very large group of small proteins. I know it's kind of a little confusing when you say it out loud. So there's a lot of different cytokines. They generally are secreted by immune cells. We know of over 100 different ones. And these serve as chemical messages. So this is going to help signal to another cell on what to do or what's going on. So they are going to help the immune system kind of regulate itself in terms of what are these cells supposed to do. So it's kind of like the immune system's version of a hormone. They're going to help regulate how intense the immune response is, how long is the immune system going to respond, and in what way is the immune system going to respond. Are we going to ramp up something like inflammation? Are we going to ramp down? Which particular immune cells do we need on hand, or do we need everybody on deck, right? Whatever. Now, to deliver this message, the cytokines need to travel and bind to the receptor on the target cell to signal it. So it's just like a hormone, right? A hormone has to bind to a receptor on a target cell. Cytokines are very similar. The biggest cytokine producers are the helper T cells, monocytes and macrophages, but really these are all over the place. Like pretty much every immune cell is going to produce them, and a lot of non-immune cells are going to produce them too. So really useful chemical. And then we get into our lines of defense. So how do we protect ourselves? And generally speaking, we can give ourselves 3 different lines of defense. The first line is the barrier level. This can be a chemical or a physical barrier. This is just to block infection. Basically, if we prevent the infectious agent from ever getting in, right, then we don't have to worry about getting sick. There's a handful of things that help with that. And we'll get into that in the next video. The second line of defense is where we start to use immune cells. So things like monocytes, things like neutrophils, but they're not specific, right? These are immune cells that will just destroy pathogens in general. And then the third line of defense, this is where we get to the adaptive side, the B's and the T cells. This is going to kick in when the first and second lines of defense have been overrun. So the way we can think of it is that the innate immune system, this is like the soldiers, the Marines, the troops that go in first, right? They're the ones just kind of boots on ground fighting against any pathogen that comes across their way. Whereas the adaptive immune response, this is going to be like the special forces or Delta Force. They're going in with a very specific mission. They've been trained for this specific mission. They're not just going to be sitting there guarding, a gate. They're going in to go after a specific target. And so that's how we can kind of think of it here with the different lines of defense. Now, if we cannot control, if these three defenses are failing, right, if we can't get there, then we can have an infection that is uncontrolled, and this is where we have an immune deficiency. So again, how do we compare innate versus adaptive? So again, innate, these are like the troops. This is what's going to happen fast. So either they're already there or they're very quickly turned on. This is going to be from a few minutes to hours, but the duration is short acting. The prime purpose is to just kind of keep things under control until special forces can get there, until a plan can be made. The innate cells do not have a memory, and so the response is the same every time. We don't learn how to respond better with the innate cells. The receptors are very broad in their specificity, so we don't have super specialized receptors for this, and this is why we can respond to so many different pathogens. And this is going to include things like the monocytes, the natural killer cells, the dendritic cells, the macrophages, the neutrophils, the mast cells, the eosinophils, the basophils, right? Those guys are going to be included there. It's also going to include things like antimicrobial peptides, the cytokines, as well as complement proteins. And then on the adaptive side, again, special forces, we are slower acting because we have to amplify cells that are generally rare. We don't keep these guys around all the time. So we're only going to build up the adaptive side or build up these types of cells when needed. And it's going to be for a long-acting response. So this is when you're fighting against this infection to eliminate it. You are not just trying to keep it controlled, you're trying to completely eradicate that particular pathogen. Now it's adaptive because we do have memory. That means that we learn from repeated exposure. And so on the adaptive side, when we get exposed, the next time we come into contact with that particular pathogen, we will get faster and better at going after it. And that will happen every time. So this is why, and we'll talk about vaccines in a little bit, but this is why things like you might have to get boosters for a vaccine, is because the more contact your adaptive immune system has with that particular pathogen, the faster and stronger the response is so that you don't even get sick. Now, since it's adaptive, these receptors are very specific. They are only going to be able to go after a specific pathogen. It's not generalized. And this is going to be comprised of T cells and B cells. These guys are also going to use antibodies and cytokines as their soluble factors as well.